Welcome to the Health Wealth Podcast and Radio Show with Forbes author and contributor Dr. Josh Luke, America's Healthcare Affordability Authority. Visit drjoshluke.com for information on speaking appearances and other resources.
Thanks for joining us for this episode. I'm here with my good friend and longtime colleague, Harry Nelson, founding partner in Nelson Hardiman Law. Harry, welcome to the show.
Thanks, Josh. Great to be with you. Thanks for having me on.
And we tried to get you guys a great background. They got a great high-rise here down in West LA, but it was so bright we couldn't get it. So you'll have to go online to check out the...
Can't count on the California sun.
Great clouds over the mountains today. A beautiful February day in Los Angeles. So I want to first start by showing you a copy of Harry's his last book that came out right after the election. And it was so cool to get a call from Harry a day or two after the election and go, hey, we're writing a book. We're going to work on this. So any thoughts you have, let me know. And to read what came about. So go ahead and show them the book.
Yeah, so this was the book that we came out with in January 2017, From Obamacare to Trump Care, Why You Should Care.
Yeah, what a great name, too.
Thanks.
And I know it did really well, and it was such an informative read. And for those of you who follow the show, the Health Wealth Nation, if you will, this won't be the first time you've heard this, but we believe firmly on this show that the feds aren't debating about bringing healthcare costs down. They're just debating who's going to pay for it. And so this show is about talking about ways that you as an individual can bring costs down. Harry's book did a great job in explaining just a history of healthcare in America and what you can expect from the Trump administration. Almost all of it's come to fruition, a lot slower than a lot of us would anticipate it just because of all the infighting in D.C. But tell us a few of the things, Harry, that you and your co-author, Rob Fuller, who's also a former hospital CEO and an attorney here at Nelson Hardiman, tell us some of the feedback you've gotten that people have really found it to be helpful.
Yeah, thanks. So we got good, really positive feedback on the book. I think there was a lot of confusion out there, particularly heading in beginning with the Trump election, about what was going to happen to the Affordable Care Act, where we were going to go from there. And so our goal was to sort of try and be a voice of reason and try to get a little bit away from the rhetoric and more down to practically on a policy level what was going to happen. And so I think one of the key things that we tried to make sure came across was that the Affordable Care Act had already made a radical transformation of care for poorer Americans as a result of the Medicaid expansion, at least in the Democratic states that didn't that accepted federal money. But that the real challenge ahead that we still hadn't solved was the question of how do we actually reduce healthcare costs, and so that for the people in the middle, particularly the Americans on the exchanges or still out there without insurance because the exchanges weren't affordable, the solution was still waiting out there, and frankly, even for all of the insured the employer-funded insurance population, we still haven't gotten to the promise ahead of higher quality, lower cost care.
Well, and so if you don't follow Harry on LinkedIn, he's a great LinkedIn influencer, and also on Twitter. Share your Twitter handle real quick.
It's at Nelson H.
At Nelson, ENELSONH on Twitter. And follow Harry Nelson on LinkedIn as well. And a lot of times I'll tag him and he tags me on stories that are related. So if you're on LinkedIn, which most of you are, make sure you follow him. So Harry, I remember early on when we talked about the book, you and I, literally the week after the election, because our phones were both ringing off the hook, because people wanted to know, hey, nobody was expecting Trump to win. What's going to happen? You guys are the experts. Tell us. And two things we agreed on were that the Republican majority would go after taxes. Nobody questioned that. And that they would go after the mandate that Americans are required to have coverage. And while there's a lot more discussed in your book, those were kind of two principles. Look, we know that's where they're going to start because that's just politics. We've seen those things happen. I found it interesting that just last week they showed that I think the drop in Obamacare enrollees was 5 million less this year than last year. So tell us a little bit about, since the election, we've now had time to see how much that's come to fruition. So what have you seen unfold?
So I think to me the most interesting thing, first of all, the most interesting thing was that in the summer of 2017, we saw that there were 9 Republican senators who switched over to defend the Medicaid expansion. So the Medicaid expansion was, by many measures, a huge success, right? And we saw it particularly in states that were hard hit with the opioid crisis, states like Ohio and West Virginia. There was an entrenched support that was actually, at least in some part, bipartisan for Medicaid expansion. The problem with the exchanges, and the reason I think that even the Republican senators, Collins and Murkowski, who had joined with Senator McCain to stop the repeal of the mandate in the summer. The reason that they finally essentially went along with it in the tax bill was that the exchanges have always been broken. Right, the exchanges were kind of an imperfect solution. We couldn't decide how much we wanted middle-class Americans to pay. The reality was we didn't make healthcare affordable for middle-class Americans, and so the exchanges, while it was a setback for anybody who believed in the model of the Affordable Care Act, I think everyone has to acknowledge that the model with regard to the subsidization of the exchanges was broken, and we're still in search of a model for affordable care.
Well, and it's been an interesting time since the election because you wrote a book on it. I tweet and post a lot on it. And even though you and I are not people who are pushing political agendas, because our opinion is sought after on what's going to happen, it was awesome to see how politically charged and motivated the comments were. Like, nobody could read our stuff without slamming one side or the other.
Yeah,
right?
No, I have to say the funny thing was, the best thing about the whole debate to me was it energized people, and a lot of people obviously have strong feelings. I was really surprised by the extent to which single payer has become a focal point. We're going to be hearing more about that from the progressive side. The good news is that more awareness, more interest is driving, I think is going to drive us closer to a solution on healthcare affordability.
Yeah, and we're going to get into that a little bit more here. And so Harry mentioned single payer, and again, I'll go back to single payer doesn't solve the problem that there's no transparency from hospitals, that they're not sharing their prices, and that healthcare hyperinflation continues to go up. So I get asked all the time, and in my last book, Execute, we talked, I think one of the final chapters was, are we going to end up single payer? And my answer was, gosh, I don't know, but it doesn't solve the affordability problem. The affordability problem comes to accountability for the cost of procedures and how the fee-for-service model really created an environment with no checks and balances. So I want to hit one more point on kind of the political side, which we don't get into too much, which is, Harry, give me your opinion on this, because for somebody who while I teach public policy at USC, I don't consider myself a legal or policy expert beyond just what I need to know to help educate people. But it seemed to me that the exchange bubble was bursting before the election, and the Democratic Party in particular was trying so hard to keep it from bursting until after the election. But there were a couple states, even Democratic-led states that came out and said, sorry, we can't go another day. So how much of that played into a role that 2 or 3 of the states had to kind of come clean that this isn't working before the election? And what have you seen since the election in terms of the exchanges?
Yeah, I think first of all, I think it's a different picture in different parts of the country. California is probably the healthiest exchange, and if you look, if you take an honest look, there's still lots of ways in which California's exchange itself was sick. So, the bottom line is that it was a nice theory that young, healthy Americans were going to come in sufficient numbers to subsidize the more expensive care for the elderly, for sicker Americans, but it just has not played out. And so I think that the reality is that the exchanges were a compromise, right?
Yeah,
There was a segment. In fact, a lot of people have pointed to evidence that Barack Obama himself may have been an advocate of single payer and really put that to the side. Speaker Pelosi clearly was an advocate of single payer because they couldn't win moderate Democratic voices. People like, at the time, Senator Lieberman from Connecticut, they used to joke that you called him the senator from Etna because Etna's home state is Connecticut. They couldn't get consensus within the Democratic Party unless they came up with this compromise where there was some burden borne by individuals and some subsidization. And the problem is that the system didn't work. And they were in such a rush to pass legislation back in 2010 that they also didn't put the cost-saving subsidies on sound legislative footing. So there was a lot of everybody. I sort of feel like it's kind of a very sick patient who everyone's trying to save, but at the end of the day, we're going to need to find a different solution than the exchanges.
It's interesting. So yesterday I was at a value-based care event in Newport Beach with the CEO of a medical group from St. Louis, who was one of the early conveners as a medical group for bundled payments, and has done so well that his company's grown all over the country as a convener. And I said to him, hey, first of all, congratulations for being an early adopter. That's great. And clearly you guys have best practices and you've shown that this can be done right when everybody's on the same page. But is the answer to this problem that when you guys finally get this right in 3 or 4 years, when we get it right as a nation, that it's not going to matter anymore because bundles and ACOs are going to go away because we've seen this massive massive move towards consumer-driven healthcare in 2018. And I want to give you a sequence of things that have happened. And of course, my role in it is minor. But when I released this book, Health Wealth, Is Healthcare Bankrupting Your Business? 9 Steps to Financial Recovery, that was January 18th. And thanks to a lot of you, it went to #1 on Amazon on the first day. But guess what happened in the next 3 weeks? Within a week, Apple announced they have partnered with 12 health systems nationally to put your electronic medical record in your hand, in the palm of your hand, anytime you want it, right here on your phone. A week later, what happened? Amazon, JP Morgan, Berkshire Hathaway partnered up and said, hey, we're going to blow up the system. We can't do this anymore. We've reached our tipping point with healthcare spending. We're going to recreate the whole way that we deliver healthcare to our employees. That's consumer driven. And then what happened a week after that? Disney Florida said, we're blowing it up too. We can't do it anymore. And Harry and I live here in Southern California, and Disney's got a presence from my home county of Orange all the way up here to LA to Burbank. You can only imagine it's just a matter of weeks or months before they announce who they're going to partner with. And it's fun for Harry and I to sit around and go, which health system are they going to partner with that covers all those areas? But that's not the point. The point is the big boys. The big boys are saying enough is enough. We've reached our tipping point. So tell me what you've seen from a legal perspective. Harry is the founding partner of one of the most prominent healthcare law firms in the country. They're based here in Los Angeles, but they have a presence nationally. What are you seeing that people are talking about, asking for input on, as it comes to consumer-driven healthcare?
So it's a good question. I think that we're seeing trends. What we're seeing, I think, in some respects, is that the paralysis or the glacial pace of change in Washington D.C. is sort of moving the driving force away from government. It's not that Medicare and Medicaid obviously are significant. All the federal health programs that cover probably over 45% of Americans are a key piece of the puzzle. But what we're seeing is that employers, like Amazon, who you mentioned, and this trend has been going on for a while, are increasingly being proactive and saying we are going to drive the health and the healthcare costs of our employees. We're not going to be passive recipients. And I think that you're seeing that the consumer-driven trend is the same thing playing out on an individual level. Consumers feel empowered, right? You hold us. My 16-year-old son isn't going out to get his driver's license in such a hurry because he's got
somebody's at the door.
Yeah, there he's speaking, he's calling. No, because he's got his smartphone, right? The smartphone has empowered people. We can purchase what we want, we can talk to who we want, we can express what we want, and consumers are also not willing to be passive anymore. And so you're seeing that a lot of smart healthcare providers are responding to that and putting out solutions to let people drive their own healthcare. So you have employers and consumers really in some ways wresting control from government in driving the future of U.S. healthcare.
Well, and it's inevitable because we can't afford healthcare. I mean, the well-to-do can't even afford healthcare in America. So the middle class and the lower class are really struggling with that, even with the government program. So, and it's ironic you say that, but my son just turned 16. He didn't want his driver's license either because we've always done everything for him and enabled him. We actually said, we want you to get it, and he's gotten it, and he drives like a half a mile every other day to go to the Taco Bell or something, and that's great for us because we want him to build that confidence. So it's such a true sign of this generation. So let's talk about direct primary care. I work very closely with Transcend On-Site Care here in Southern California. They're one of the national leaders in direct primary care. I think most of the Health Wealth Nation knows what direct primary care is, but for those who don't, let me give you the 30-second version. If your company spends $10 million a year on healthcare, whether it's with Blue Cross or Cigna or somebody else, with DPC, you would say, hey, Blue Cross Blue Shield, like life and auto insurance is only catastrophic, we're going to take the same approach with our healthcare. So instead of $10 million to you this year, we're just going to take $4 million and give it to you. We're going to take $4 million and give it to this local primary care practice that also has a bunch of specialists. We have so many employees here in this area that we want them to be able to walk in 24/7 in some cases, but more often than not walk in for a decent portion of the day, but be able to call you the rest of the day and get access to a physician or physician assistant. And we also want telehealth and remote monitoring capabilities. And I know you've heard this story from me before, but here's the 10-second version. The days of mom with 3 kids having to take them all to school, and then one wakes up sick and says, oh, Mom, I don't feel good. Mom's got to change her plans. Mom's got to call the doctor, figure out when he or she can see him, go sit in the germ-infested waiting room, cancel all of her plans for the day. The minute you're willing to accept that you can, from your phone at 7 a.m., say, I need a doctor consult from my couch in 20 minutes, and it's over with 30 minutes later, and the pharmacist has already been contacted with what your child needs, mom realizes, hey, Dad, I want that policy. I want that telehealth policy. So that's all part of direct primary care. And so, Harry, tell us a little bit about the work you're doing in direct primary care, which is a really quick way with great return on investment for Fortune 500 and mid-market companies of any industry to save significantly on healthcare spending.
Yeah, so direct primary care we've been seeing it for a few years, but there's absolutely a big upward trend. I think on the providers, I always get a lot of provider groups around the country calling us, and they're thinking about doing it. I always say the first thing is from the provider side is you have to do the numbers and make sure you have a population and a model that's going to support it. But if you do, assuming that I think it's a model that really, by cutting insurance out of the equation and saying we're going to take a low monthly fees, but regular monthly fees, and we're going to build a population who needs this help, you can essentially create a much more convenient framework for the patients and for the doctors. I know of a number of practices that have it's transformed the lives of the doctors working in them. We have a couple clients who actually were in the early leaders in the DPC movement, and I think it's going to continue. I also think we're going to see a lot more other kinds of tailored, more customized telehealth solutions to meet the needs of both individuals and also to meet more employer needs.
So let's talk about that. And so DPC, guys, awesome, so cool. And look, if I'm a doctor and you come to me and go, hey, can I give you $1 million a year, fixed cost or a fixed income for your practice, and all I need is access and maybe you to bring in a specialist. What a great thing for your practice as a physician, right? As long as you said there's the volume out there to support it. So that's one of the 9 steps in Health Wealth.
Sorry to interrupt you. Just so for anybody who's out there listening, just as a lawyer, I feel obligated to say, number one, you need to work with an actuary and to get the financial part. And then you need to check with your state laws. Here in California, we have the Knox-Keene Act, which regulates who's allowed to hold themselves out. And one of the things that lawyers can often do is structure either to comply with the law or to build the plan such that it doesn't affect the law.
So you just found out why on the website health-wealth.com. It's the same as the book, health-wealth.com. When you click on partners, you're going to see experts like Harry, he's right there, that when you decide, hey, we want to look into DPC, I've heard and I've read and I've studied that it's one of the quickest ways for us to improve care, improve satisfaction for our employees, and to save a bunch of money. The first call you make is to Harry to put you in touch with those right people, because there's going to be legal hurdles at every step of the way. So check out Health Wealth Partners at health-wealth.com. That's why they're there. I guess you could call Health Wealth Partners a consultancy, but it's really me being a matchmaker for you when you say, hey, we've declared our tipping point. We can't keep paying this much for healthcare. We want to employ a handful of these 9 steps to financial recovery. You just heard about one of them, direct primary care. I want to ask Harry about another one, because Harry, although he is probably one of the top attorneys nationally in healthcare, in my mind, the top attorney nationally, he also works for a firm that has expertise in 2 or 3 other areas, and those areas are way more advanced than healthcare on telehealth, and that is medicinal marijuana, and that is also in the opioid crisis. So Harry, tell us about, I don't get too far into those industries, but what I want to do is say, why is it that those industries have been using telehealth and remote monitoring for almost 4 or 5 years now, and in healthcare we just haven't adopted it as much?
Telehealth adoption has been happening. The problem is a lot of the law is slow to catch up. The law, you see even on marijuana, as we sit here today, here in California, completely legal for adult recreational use or medicinal purposes here, but Washington D.C. we're still waiting.
I have to interrupt with this. The article in the paper yesterday in Orange County said Girl Scouts grappling with if they should be selling cookies next door to the marijuana distributorship. So I thought that was great.
The key thing is that the law is a lagging indicator. The law it takes a long time for our laws to catch up to our technology and our needs. So it's interesting. As a lawyer, I've tried to focus on the needs that are out there, and when we see unmet needs, we've taken on problems. So 8-9 years ago, when people came to us asking about marijuana compliance, we looked around and we said, no one else is doing this, we need to figure out the solution. So too, addiction treatment. A lot of people think there's an inconsistency between these 2 things, although I really think they're deeply connected.
Sure.
We have, in some sense, the healthcare crisis in this country has an underlying pain crisis, right? And so anyway, so we also took a lead in addiction treatment. We've been doing work nationally, and I think that what we're seeing is that telehealth is a huge piece of the puzzle. The reality is that we have a massive shortage of physicians, so people can't get access to the care they need. In many cases, our system is just inefficient. And so telehealth is going to be a bigger and bigger piece of the puzzle. What's exciting to me is that we're starting to see a new generation of telehealth. Originally, telehealth
Sure.
was just companies like Teladoc, where you'd go online and you'd have essentially a Skype type encounter with your doctor. But what we're seeing today is algorithm-driven telehealth, asynchronous telehealth, where you get hyper-efficient solutions and you get much faster diagnosis and therapeutic options for patients. So I'm excited about that.
Yeah, and likewise, I know Harry, like myself, we might be Gen Xers, but we're big fans of millennial culture, and I think both of us would attribute some of our success in business in the last 10 or 15 years to our willingness to step back and say, what are millennials doing that I could learn from? And technology was definitely one of them. And I agree with Harry. I mean, Harry and I were out there speaking at conferences and seeing this technology in 2012, 13, 14, and you just kind of like, so you're seeing a doctor on Skype. I mean, I get it, but it doesn't feel great. It's so much better now. It's so much more interactive. There's so many tools. There's remote monitoring devices. So be willing to give it a chance. And I always share that story of the mom with 3 kids because it really personalizes how it can transform your day as an individual, and you might actually get a better opinion from a doctor who's a specialist in what your kid's struggling with than just going to the normal doctor down the street. So Harry and I have talked about 2 of the 9 steps to financial recovery and health wealth. I want to talk about another one, which is DNA testing or genome sequencing. I'm a firm believer, and for those of you who listen to the show, you know my big thing is become an EHC, an engaged healthcare consumer. The way to do that is 3 Ps. Have a plan that's based on personalized medicine and preventative medicine. And the quickest way to personalize medicine, and you can just watch TV and see all the ads right now with genealogy and DNA testing. Get your DNA test. It costs anywhere from $300 to $1,300. Your employer may pay for it. If not, your health savings account at the end of the year can pay for it. And then get a consult with a pharmacist or a doctor to get a pharmacogenetic review that says, hey, this medicine you've been taking or your kid's been taking consistently for 3 years at a cost of $600 a month. Guess what? It doesn't even work on your kid. So here's a list of ones that might. So that's my perspective on pharmacogenetics. It is true personalized medicine. But I want to hear from Harry what he's seeing on the other side, the provider side, about what's the hot topics in DNA testing and genome sequencing as you see us growing into 2018.
So genetic testing has become a much bigger topic. I think we're in the early days still. I think we're going to see significant advances in how practically the information can be used. As with everything in healthcare, you have to be careful because there's a sort of fraud and abuse potential.
Sure.
There's a lot of genetic testing out there that is just running a test that's not going to be used by a doctor or seen by a doctor. I would always caution people, if you're thinking, and companies, if you're thinking about testing, you want to say, who's the doctor who's recommending this test, and what are they going to do with this information? So I do think we're starting to see incredible diagnostic ability to test for risk of different disease and different conditions from genetics. I think it's going to get a lot more. And as you mentioned, one of the most interesting things to me is figuring out medication, which medications you should be on, and dosing. I in a way, I actually think, and this may be a radical statement, but I think we're living in the end of a period where you go to the pharmacy and you get that sort of set pill. Yeah. I'm not saying it's going away in the next decade, but we're headed towards a future where, based on personalized genetic information, you are going to get a specific medication that's not a general recommendation and a very specific dosing for you personally. And that's huge progress in terms of disease management and really a radical change ahead.
And I want to tell a story before we moved on, because you just touched on a couple of the other steps to health wealth. But Harry and I have been working together for years. And when DNA testing got covered by Medicare, I want to say it was 2014. And it was kind of short-lived because a lot of abuse came really quick and Medicare slowed it down. But I had several organizations come to me as somebody who was helping transform care from just a fee-for-service heads and beds model in hospitals to value-based care outside, and said, hey, DNA testing, it's here, Medicare reimburses, help us. So I went to a few nursing homes, and one of them saw the value in it. And so we got consent from a handful, maybe 15 patients that had Medicare benefit, to swab them and get their DNA sample. We got buy-in from all the active physicians and the medical director. And I remember vividly the meeting at the nursing home when we got it and the doctors came back. They all had this look of fear in their eyes for the reasons that you just said. They realized that the market was not ready for this test yet. And let me give you an example, because Harry just hit on it. And this is why in my book, I'm gonna finish by telling you in the book exactly what it tells you to do with your DNA makeup. You take a picture of it and you take it to your doctor and say, here's what I need. Because he or she's not gonna do it because we're not ready for it technology-wise. Because these doctors in the nursing home said, oh my goodness. So now I know what works on this individual. I also know that we've been prescribing something that may not have worked for a long time and justifying that it did. But here's the problem. The minute they transfer out 911 out to the hospital has its own formulary. They're going to discharge everything we did. They're going to prescribe a medication that we now know isn't effective. Patient's going to die. We're all going to get sued and we'll have no argument. And that's exactly what I just heard you say.
Yeah, exactly. No, I think that's a big risk. So I think we're still a little early on it. By the way, one of the things that I think there's other tools that are coming out from technology that are interesting, that are a little simpler, but actually have incredible information for people. I've been learning about a startup, an Israeli health tech startup called Likely, and what Likely does is they'll take a blood test that you took 2 years ago and compare it to a blood test today, and they'll do an analysis today. So I think there's a lot of opportunities ahead. Machine learning is going to take us far.
Yeah.
But right now, I'd still think genetic testing is still a little bit away from being really targeted as a solution.
So DNA testing, genetic testing, full genome sequencing, the point is if you're going to do it, and we're going to talk about why and who is doing it, get the report, take a picture, you own it, you lobby the doctor. You'd be amazed how many doctors will tell you no the first time through, and then you go, hey doc, if you're not going to do it, I'm going to find somebody that will. They need to be able to say the patient has requested it, the patient has their DNA makeup. This is going to cover their liability, because any doctor that's not a millennial is still living in a day where they're worried about the liability of the decisions they make.
Thanks for tuning in to this episode of the Health Wealth Podcast and Radio Show with Forbes author and contributor Dr. Josh Luke, America's Healthcare Affordability Authority. Visit drjoshluke.com for information on speaking appearances and other resources.